Welcome to today's session, Regional Anesthesia for Heat Surgery. This is Jensen from Vermeylen Medical. Nice to meet you. We are honored to invite Dr. Philip, Dr. Kris, Dr. Peng, and Mr. George to be our presenter today. Dr. Philip will present Peng block. Good morning, Dr. Philip. Good morning. Dr. Kris will introduce facial iliac block. Good afternoon, Dr. Kris. And Dr. Peng will be our moderator during the webinar. Maybe good evening, Dr. Peng. And Mr. George will introduce ultrasound application in anesthesia. Hello, George.
Hello, good evening.
Good evening. If you have any question during the presentation, please type them into the question box in your Zoom control panel. We will have time for questions at the end. After this webinar, there will be a survey. Each attendee will receive the certificate from the CPD unit after fill out the survey. And firstly, I will introduce Dr. Peng.
Great, thank you very much. Let me just do the share screen.
Philip, first introduce me.
And Dr. Philip, I will introduce the Dr. Peng. Dr. Penafrancia Cano is currently session head, associate professor of Department of Anesthesiology, University of Philippine General Hospital. She is board certified in anesthesiology and received special training at University of Philippines. As current Vice President of Philippine Society of Anesthesiology, Dr. Peng is devoted to educational research and scientific activities. She has joined more than 100 academic activities in anesthesiology. She is also the member of many international societies. From 1993 to 2001, Dr. Peng was Associate Professor at Department of Biochemistry and Molecular Biology, University of Philippines. From 2001 to 2008, she was Section Chief of Ambulatory Anesthesia Department of Anesthesiology, University of Philippines. From 2008 to 2017, she was Section Chief of Orthopedic Anesthesia at Department of Anesthesiology, Philippine General Hospital. Okay, let's welcome Dr. Peng.
Good evening. Thank you, Jensen, for the very nice introduction. Good evening to everyone in the Philippines and the rest of Asia. Tonight, we are very much elated because we have attendees coming from different countries around the world. Wherever you are coming from, on behalf of the Manila Academy of Regional Anesthesia and the Philippine Society of Anesthesiologists and our industry partner, Visonic and Darren Peter, we would like to give you all a warm welcome. The webinar for today, which is the fifth among the series of webinars for the year 2021, is special because we have with us two speakers who are very well respected and very well recognized and who are both an authority in regional anesthesia. One of the goals of MARA is to propagate regional anesthesia in the region, which we have been doing since more than a decade ago. And organizing webinars with experts in the field as speakers is one of the means to address these goals. We do hope that you will continue to attend our future webinars, which would further inspire us to keep on going and to improve what we have started. Let me now introduce our first speaker. The first speaker is a person who needs no introduction. He was born and raised in Hong Kong, where he obtained his medical degree, but later moved to Canada, where he is presently a professor in anesthesiology at the University of Toronto and the director of pain at Mount Sinai Hospital. He is one of the most distinguished pain and regional anesthesiologists in the global community. He is also a leader a researcher, and a pioneer in the application of ultrasound for pain medicine. His innovative research has led to different new procedures in pain intervention. He has delivered more than 350 lectures and has directed numerous workshops nationally and internationally. He is an editor and reviewer of several journals, namely the Regional Anesthesia and Pain Medicine, the Canadian Journal of Anesthesia, Anesthesia and Analgesia, and the Anesthesiology Journal, to name a few. He has edited 8 books, has written almost 80 book chapters, and he has published more than 150 peer-reviewed journals. He has received a multitude of honors and educational awards, which includes the Certificate of Founder Designation in Pain Medicine by the Royal College of Physicians and Surgeons of Canada. He has also received the Distinguished Service Award from the European Society of Regional Anesthesia in recognition for his outstanding lifetime contribution in the field of regional anesthesia. But the highlight of them all is he is a recipient of the John J. Bonica Award, which he received last November of 2020 from the American Society of Regional Anesthesia. It is the highest award in pain medicine, which is given to individuals with outstanding contributions to the development, teaching, and practice of pain medicine. Without further ado, friends and colleagues, it is with pride that we are going to welcome now the very prominent and very distinguished guest, Dr. Philip Peng, as he enlightens us about the Peng block. Philip?
Thank you. Thank you very much. I'm very humbled to hear this introduction. I'm going to use the share screen here. Perfect. I hope you all can see the slide. And thank you very much for the introduction and greetings to all my friends and colleagues in the Philippines and in Asia. I just browsed through the participant list and I saw quite a number of individuals that I remember the name, including someone from Qatar. And I'm very glad that I'm in the same podium, virtual podium with my friend Kris from Belgium. And we have some good time last time in 2019 in ESRA, and then the COVID came and haven't been traveled since. This is my disclosure slides. Being the first one who speak, I think I have a luxury to talk about something very important, not just go directly to the block, but talk about the interaction between the hip analgesia, the type of blocks, whether it's Peng block, Fascia block, and the type of a surgery, because each type of surgery have a different the signature in terms of the incision, soft tissue trauma. Not knowing the type of surgery or soft tissue trauma, and not knowing what innovation of this type of soft tissue trauma, is very difficult to make sense of what the hip block can provide. So I'm going to give you a very general introduction. Then yes, I'm going to talk about the basis for the pericapsular nerve group block, and some people call it Peng block, and then the clinical evidence. And finally, I will share with you some of the tips that I have this for the last few years. All right, the first thing is hip surgery. Is a spectrum. Is a spectrum of a different type of surgery. That even for the hip fracture, we talk about the management of a hip fracture itself or the surgery. And it can be intracapsular or extracapsular or something very similar to fracture femur. And the type of surgery is different. And then we have the hip arthroplasty, which have different approaches, and we have hip arthroscopy. If you think about this, the management of the hip fracture itself without the surgery and the hip arthroscopy, they are the fairly unique because the pain is coming from mainly intracapsular event, means the capsule ligament and also the bone inside. They are very similar, I think, by capturing the pain or the innervation of the capsule or inside will be sufficient. But it's important to remember there are 3 components of the insult from the surgery. It can be from the bone and the capsule. Now remember, even though you are talking about the hip replacement, joint replacement, they replace the joint. They still keep the capsule and the surrounding tissue intact, the ligament around. The capsule ligament and the bone, they share the similar innervation. So the pain is still there, even though you remove the bone. And you have a different skin incisions, and you have something in between the skin and the joint, which is the muscles. And different surgery, we have a different trauma to different muscles. So, and to illustrate, I'm going to just talk about the type of surgery, because when you talk about surgeries, it's not just about the capsule, the pain, but also about the skin and the incision and also the soft tissue. Now remember, even hip arthroscopy, a pure injury to the soft tissue, to the joint or intracapsular event, but the setup itself varies. I work in 2 centers, and one of the surgeons using something like a torturing device to track the hip in order to gain the maximum access to the hip joint. And it itself can cause a lot of soft tissue pain just by pulling the muscle. This is a very good summary that with the help of my friend from Colombia draw this. Each individual color represent the nerve here. So the lateral femoral cutaneous represent most of the incision will involve. But if you think about the type of surgery here, the dynamic hip screw are the one probably just go along the hip incision from the lateral femoral cutaneous. The intramedullary now, they actually involve here, which is iliohypogastric, and sometimes higher to the subcostal nerve. And for the different type of arthroplasty, depends on the incision. The lateral incision, the lateral approach, definitely involve more than lateral femoral cutaneous, and here is iliohypogastric. The posterior involve iliohypogastric and superior cranial nerve, and anterior approach, mainly the lateral femoral cutaneous and iliohypogastric. So you can see just the different approach have a different incisions, not just lateral femoral cutaneous. All right, think about this. What about the soft tissue? We talk about the capsule, we talk about the incision, soft tissue. When you do the lateral approach for the hip screw, by the way, I'm fairly old, I'm an old man. So 30 years ago, I was trained in Hong Kong in orthopedic surgery. I've done all this hip surgery. So I know exactly what I have gone through, I've done in terms of a tissue trauma. To do the dynamic hip screw, I need to cut the fascia lata. I need to expose the vastus lateralis. So yes, the femoral nerve block may have for the soft tissue trauma from the muscle here. The intramedullary now probably have a smaller event to the soft tissue trauma like vastus lateralis and small muscle here, small muscle there. But let's talk about the hip arthroplasty. When you do the lateral approach, which is not that popular in our center and most of Canada, because most of people use posterior and anterior. This approach, you make a cut all the way, and then you need to remove or detach the gluteus medius and minimus. And when we say detach, you really use a cautery to cut. I just by look at this, I think there's a lot of pain from the gluteus muscle, and that is from the sacral plexus area. Most of people using the posterior approach. Posterior approach, you split the muscle in the gluteus maximus from the sacral plexus, and then you see the short rotator and you cut this. And again, is a lot of pain from the posterior capsule here and the muscle which from the sacral plexus. Anterior approach is probably the approach that most of the people who do ambulatory, means same-day hip surgery do, because what they have done is find an interval between the fascia lata and also sartorius and split them. So there's no cutting of the muscle, just split them soft tissue plane. And if you pull these two muscles apart, you can see the capsule itself. The only problem that is not that popular, because you don't see the joint, the head and neck itself so well. So when you do the cut, you don't have the lateral and the posterior approach to see the head and neck that well. You need X-ray to see whether you make a perfect cut. So there's the only thing that you need, but in terms of the timing, is basically the same time as a posterior and lateral approach. And that's the reason why the anterior approach are the favorite approach for the same-day surgery. All right, so our three components, we know that one of the component is a hip capsule. So this is a very, very good article just published, summarizing the last 200 years of those hip capsule innovation, anterior and posterior. And they actually systemic review. There's a busy slide, but I just want to zoom a little bit here. They try to look at the quality of those different anatomical study, but just coincident, the only study that hit the yes in all different category. Somehow is from Toronto, is where we work on, and this probably they rate the highest. And what they say is very simple. If you look at the two landmark, the anterior inferior iliac spine, the iliopubic eminence, the yellow and the red dot here, you see all this bundle fiber here. That's a femoral articular branches, deep, emphasized, deep to the psoas muscle. And then it cover basically every part of the femoral head and the neck. If you look at the iliopubic eminence, there's a nerve that cross over the iliopubic eminence. That is the accessory obturator nerve. It doesn't happen in all individual, but if you have those nerve, 100% of this will supply the hip joint, mainly the medial aspect. And this is a insert, this little yellow, a red hole here is the obturator foramen, and it's the main trunk of obturator nerve. But its center articular branches to supply the bottom half of the femoral head and neck. And here, this part is called inframedial acetabulum. And this is the landmark that you can find the articular branches here. So this is a summary slide. Femoral nerve supply all four parts. The accessory obturator nerve supply the medial part, and obturator nerve supply the bottom part. Posterior capsule, and this systemic review have highlight three nerve to quadratus femoris, superior gluteal nerve, and sciatic nerve. And this again, another study published again this year, focus on just the posterior capsule. But the only message you need to know, is if there's one nerve you need to single out consistently to supply the posterior capsule is the nerve to quadratus femoris. And we have the way to find it, but it's outside of the scope of this discussion. Is the posterior innervation important? But it's very debatable. So let me just share with you why. This is an article published in 2012. They look at the histological staining and find that the posterior capsule, yes, have a lot of sensory fiber, but they are mainly the mechanical receptor. They feel the stretch, but they don't have a lot of those nociceptive fiber. So most of the nociceptive fiber are basically in the anterior. So if you want to deal with the pain, yes, you deal with this. But this is the histological staining, but under normal circumstances, and it's also true. But when you have a pathological situation, right, you have a hip fracture or you have a osteoarthritis, there's a process called central sensitization. And those mechanical receptor or the silent receptor can change from mechanical to nociceptive, which is basically we know it's called the process of sensitization or recruitment. And it happened in some situation because in Hong Kong, we are working with a group that we understand that by blocking the posterior capsule in hip fracture, it actually can give additional benefit, but again, is outside the scope. But again, under normal circumstances, the anterior fiber is the most important part. All right, so summary, I think I summarized there is three components when we talk about the innovation. The joint capsule, which I'm going to focus more on the block for the joint capsule and the content inside, a skin incision, and a soft tissue itself. Okay, talk about the pericapsular nerve root block. What's Peng block? This is, as I say, is a pericapsular nerve root block. It blocks the group of nerve around the capsule. What does it mean? So I just summarized between the AIIS and iliopubic eminence. We have this articular branches from the femoral nerve. We have articular branches from the accessory obturator. And then we have the articular branches from the obturator going past by the iliopubic eminence. So if you think about this, these three landmarks are the most important. So for chronic pain, if we do the radio frequency ablation, I have to deal with point by point. In regional anesthesia, there's a secret. The secret we call 20cc. If you put the needle somewhere around the nerve and put 20 cc there, you can get most of the nerve. And that is the reason why we put 20 cc around the capsule. And if we put 20 cc between these two landmarks, AIIS in iliopubic eminence, you can probably just spread along here and maybe even on the medial capsule. So is it true? So well, we have done this. So when we inject 10 cc here, no doubt, actually, even if we put 5 cc here, it spread really well between the AIIS and iliopubic eminence. But it didn't spread to the medial capsule. It didn't get the obturator. But when you inject 20 cc, you can see it pretty well. You cover all the nerve group here. And this is the AIIS. This is all the dye, and even on the medial capsule. Medial capsule is all covered. Normally, when we do the femoral nerve block or fascia block, we inject the local anesthetic superficial to the psoas muscle. For the Peng block, we inject deep to the psoas muscle. This is important to understand. Again, the fascia lata, so block for the infrainguinal, you inject superficial to the muscle and hope that it will spread above. But it won't cover the articular branches because the infrainguinal, but Kris is going to talk about something superinguinal. But infrainguinal, even though you use 30 cc, is spread up to S1 or L5. It's not high enough to cover the articular branches because the articular branches left around L4-5. Ultrasound, we can see this area very well. The AIIS is somewhere deep and a bony prominence here. And when we pivot, so align the iliopubic eminence and the AIIS, we see this beautiful pictures. And here is psoas tendon. And the target is deep to this psoas tendon here. Now I'm going to talk about, not going to talk about this. This is more for chronic pain. Okay, what's the evidence? Well, the first article published is quite interesting. So one of my fellow who put 20 cc in a space, and then the first patient actually have no pain to the extent that she thinks there's no fracture and she want to walk. I'm not kidding. She want to walk out of the table. And then we have to ask the surgeon to show the patient the x-ray that the anesthesia team fix your pain, but not your fracture. And the patient lie down and have a surgery. So it's that dramatic. So then we just studied the 5 consecutive patients. Oops, sorry. So these are the Peng score. So this is before the block, the Peng score at rest. And after the block, there's no pain. That's why you don't see a bar here. The only one still have some pain at rest is here who have the metastatic disease on fentanyl patch 200 microgram. So the metastatic disease infiltrate the whole femoral head and neck and even femur. So that's why the patient still have some pain at rest. But the pain with movement is dramatic. We are talking about this before the block and after the block. We are talking about an effect size of drop at 7 out of 10. And it is very dramatic in what we've seen in the past. And this is not something that we have done, but the review article on those case series reproduce a lot of those results. And one of the articles published here in Indian Journal of Anesthesia, they talk about how good it is actually after the block, they do the spinal. They actually, between the two, they want to turn the patient or that the patient turn themselves and ask the patient the Peng score on turning and reproduce the same result that we experienced. The patient have a dramatic differences in the Peng score. And certainly this is just to convince you, it's very good to deal with the capsular pain. And in Hong Kong, there's a group of investigators. I showed them and discussed with them in terms of the Peng block, and there is a group population that they are so sick. They are ASA 5 or 5 minus. They cannot have a surgery, and they are left to die. So they have no dignity because they will die from bed sore, hypostatic pneumonia. So what this group doing is very, very ingenious. They put alcohol in the area and take away the pain. And yes, we put the alcohol here in the Peng area, but also we put one in the inframedial acetabulum because we cannot inject 20 cc. We inject much smaller volume, so we need to have additional needle in the infrapubic eminence. And within 5 days, 50% of them can sit up. It's very dramatic because if they can sit up, they can have the lunch and dinner. They don't aspirate. They rarely have best sore. And this is actually the submission Peng score, because a lot of them, they have dementia. So they use a composite Peng score, maximum is 3, minimum is 0. And the Peng score on hip fraction 45 degree. And here, see, actually, it's from 10 minutes to 5 days, they drop dramatically here. So these are all case series. What about the surgery itself? So it's not just fracture, because the fracture patients still have a surgery. So this is the RCT, not the RCT comparative trial done, published recently. Probably some of you have read this, from Australian group. They randomized the 2 group of fracture having surgery, and one of them, they have the Peng block, the other have the femoral nerve block. And this is interesting. This is a pragmatic trial. 60 patients developed in the 2 groups. Why I say pragmatic trial? Well, first of all, femoral nerve block, not a lot of centers doing this. Yeah, they have done this because it's pragmatic, because it's what they have been doing all the time. And you can see it's a very heterogeneous group. They have intracapsular, extracapsular patients. They have different surgery. They even have a spinal or GA, and they even have an epimorph or not. So they are not changing anything they are doing. What they have done is randomize them either to conventional femoral nerve block or the Peng block. And despite all this, we are talking about the femoral nerve block, which basically block everything that you really want to block. And this is the result. When you talk about the Peng score at fourth hour, they call it the day 0 recovery room unit. It's actually the 4th hour. You see the huge difference in terms of the Peng score. Look at the none or mild. And this actually, most of the patients with a Peng block have none or mild pain compared with the femoral nerve block. Interestingly, talk about the quadricep weakness. For those, we expect femoral nerve block, all of them, but some of them, they don't have the weakness. None of them have no weakness. Everyone have the weakness. But then for the Peng block, 10 of them, they have some weakness. I'm going to address this in a moment. All right, so hip surgery is not just hip fracture. What about the hemiarthroplasty? There's some case review, case series published in Canada. This is an interesting study. They actually look at the chart review for those patients who have done LIA, the local anesthetic infiltration. Itself, it decreased the hydromorphone consumption in 24 hours from 43 milligrams to 29. So, but then they are not stopping there. For those patients all have LIA, they add a Peng block and look at chart review, and they still, with this, they still can further decrease the hydromorphone consumption. Again, it's not huge, but it just gives you a favor that the Peng block is not just the local anesthetic infiltration. Is there any randomized controlled trial? Actually, one is coming, but I cannot give you all too much details because this is not published yet. But this is a group from Europe. They do it between the control and also the Peng block. One thing that's very interesting is that they have a very, very good multimodal. They give everything pre-op, all the dream medications, and they give post-op ketorolac, acetaminophen. They even also have a sublingual PCA sulfentol, and they have the surgeon infiltrate the wound in order to control the skin incision, and all have a spinal but no epimorph. Despite all this, they still find a very huge difference in the 12 hours. This is one with Peng block, the control, 12 hours to 24 and up to 48 hours. And still have a very good differences between the two. And the morphine consumption in terms of sulfentol consumption, Peng block was controlled. So I can't wait for this publication to come out. All right, so what about hip arthroscopy? And we don't have this yet, but there's some studies showing it's very promising. But my colleague Ricky Brew, he have a RCT and have a big numbers on hip arthroscopy. And in the University of Virginia, they also have a big number. They publish an abstract, and so it's very promising. So again, it's in the pipeline that the big RCT for the hip arthroscopy. All right, so I am almost done here. I just want to share with you quickly the pearl. I think when you put a needle here, usually we indent the tissue. But when you are the psoas fascia, when the back on the bone, you need to really rotate and pierce the fascia in order to get the fascial lift. If not, then what you see here, this fascial lift, you see most of local anesthetic spread here. There's a needle track, and you can track back, so it's not a very good idea. So I just want to show you here, there's a video. I put a needle, I see the psoas fascia, there's a bone. I rotate my needle, and then when I actually in the at site, I can see this fascial lift. You can see the lift, and it sometimes takes a little bit of patience to do this. And if you are not careful, so I just want to share with you, this is one of the injections. A lot of people will accept that one. You can inject, and you see that there's a fascial lift a little bit here. But then if you actually look at the other side, yes, the fascia have a lift here, but a lot of local anesthetic are here instead. So this is important, and because you are not getting a lot to those areas. And the lateral femoral cutaneous are very closely in insertion site, which is outside. This is actually your transducer is outside. So be careful when you put a needle. If the patient has some paresthesia, that you may impair the lateral femoral cutaneous nerve. And tilting is important. So when you see this picture, there's a femoral artery and there's a femoral nerve there. You want to put a needle, and the area you can insert the needle is very narrow. You don't want to hit that is the rectus femoris tendon here. So this is the area that you can put a needle, and you want to avoid the femoral nerve. But I think I would highly suggest you toggle the probe. By toggling, you have a different view. You have much wider area you can put a needle without fear to hit the femoral nerve. And this is the last line. So when you inject here, it's supposed not to contact the femoral nerve if you're truly deep to the psoas fascia. But sometimes you are not patient enough. Just like here. You put the needle, you see here, looks like you have something, but this is actually you are all in muscle here. Here's a slide actually is given to me by one of my colleagues in Europe, first done the Peng block, and I congratulate her, but then turned out that it's all in muscle, I can guarantee. So what's the problem? When you inject into the muscle, you can spread, especially when 20 cc, you can spread to the femoral nerve. There's a second area you can spread. When you inject a high volume, the junction between the paternius and the psoas are not tight. You can actually go and spread, and you can see it can go back to the femoral nerve. The third type of spread is actually here. A lot of people put the needle much closer to the AIIS, and it can spread all the way to the fascia lata and spread to the lateral femoral cutaneous and even to the femoral nerve. So this is something that I find that if you're not careful, you can get the motor block. So I think I summarized the 4 areas. I think the most important is the first few slides, talk about the interaction between incision and the innervation and your hip block. And I did cover the basis for the Peng block, clinical evidence, and share with you some of the tips. Thank you very much.
Okay, thank you, Philip, for that very informative lecture on the Peng block. Now we go to our second topic of the day. We introduce now our second speaker. Our next speaker is very famous as well, especially when it comes to hip surgery analgesia. He grew up and obtained his medical degree in Belgium and then took his anesthesiology training at the Netherlands. He initially specialized and had a keen interest in pediatric, cardiac, and emergency anesthesia, where he had served as a trauma helicopter physician at the Erasmus Medical Center in Rotterdam. A few years later, he became interested in regional anesthesia, which he practices in Turnhout, Belgium. He has given numerous lectures in national and international annual meetings and congresses. He has also acted as an instructor of countless workshops, luncheon discussions, and live demonstrations. He has served as a reviewer in several journals, namely the Acta Anesthesiologica Belgica, the European Journal of Anesthesia, and the Regional Anesthesia and Pain Medicine, to name a few. He was formerly a board member of the Belgian Association of Pediatric Anesthesia. He was also formerly a member of the Scientific Committee of the European Society of Regional Anesthesia, while at present, He's a treasurer of the Belgian Association of Regional Anesthesia. He has written several papers and has studied and published extensively on suprainguinal fascia iliaca block, which he proposed as an anterior approach to the lumbar plexus targeting the three nerves, all with just one injection. Let us now hear from no other than Dr. Kris Vermeylen, who will discuss about the mechanism and effectiveness of the suprainguinal fascia iliaca block. Kris?
Thank you for this very nice introduction. Let me also try to share my screen. I hope you can, I hope it is clear. First of all, I want to thank Philip for still calling me his friend. We already go a few years back, and I'm just, yeah, I don't have the big experience that he has, of course. But some people might think that we are concurrents or that we have to fight each other because there's in literature there is some discussion between the Peng block and the fascia iliaca, or there is some discussion if the obturator nerve is part of the fascial compartment or not. But Philip knows that I have a lot of respect for him, and all these discussions only makes our work even more nicer, I think. And we have some very nice, interesting discussions. And I think that both our work is getting more to a high standard, therefore. Let me start by saying, after this nice introduction, that I'm indeed Kris Vermeylen, that I live in Belgium, I work in Belgium, and I was raised in Belgium. And a lot of people don't know Belgium because it's a very small country, but it's situated at the North Sea, which is close to the United Kingdom. And we are situated between the sea, the Netherlands, Germany, Luxembourg, and France, which are probably more known for as international countries. I live in Antwerp, which is the second largest city of Belgium, and it's situated near the river Antwerp, which has one of the biggest ports in the world. But we're probably more famous for our paintings, our beer, and our chocolate. Now, I don't have any conflict of interest, and actually I do have one, because I'm a very big fan of the Fasciliar Compartment block. Of course, that's why I did my PhD on this block. Now, I'm very glad that Philip already started with telling you that it's not only about nerve, that's not only about just getting the technique itself, but that also other things are important in hip surgery. Therapeutic possibilities like the Fasciliar Compartment block, like the Peng block, is only one factor of the big thing around hip surgery. We have ERAS protocols, we have the prospect guidelines, we're dealing with an elderly population with a lot of comorbidities, with a high incidence of surgery, cognitive dysfunction, and rehabilitation as well is very important. So the therapeutic possibilities is only a small part of the whole package. So what are the objectives? So I'm going to talk of the Fasciliar Compartment as only one of the main players of regional techniques for hip surgery, but I also want to say something about the influence of the approach and the volume that we use for our blocks. I want to say something about influence of biodynamics, which is something rather new, and still a lot of those things are unknown. And I want to say something about block testing, segmental innervation, and some persistent pain and pain location. So it's a lot more than just talking about the Fasciliar Compartment. Philippe already showed us that basically anatomy is very important, of course. You have an anterior innervation, you have a posterior innervation, you have a lot of nerves. So we're talking about multiple nerves. It's not only talking about the hip capsule, it's not only talking about the bone. It's also important to have an idea about the innervation of the skin, about the muscles, the ligaments. And I think our therapeutic possibilities are important, or our postoperative management is important to look also after those things. A variety of regional anesthesia techniques have been shown to offer improved analgesia. That means that there is no one technique which is the best, or and the other techniques are bad. The main players are, of course, the posterior approaches of the lumbar plexus, which are more or less, I think, older techniques. They are technically much more challenging, and they are not that popular because they used to have a lot of incidents of major effects. Me, myself, I didn't get to be able to put or to learn a lot of these techniques, because at the time when I was a trainee, that was not very popular. Again, because of a lot of anatomical studies, we know that the anterior approach of the lumbar plexus are probably much more important. And the biggest players of these anterior are the femoral nerve block, which is already an old block, the Fasciliar Compartment block, which I'm going to talk about, and more recently, the pericapsular nerve group block, which Philippe talked already about. I think that the Fasciliar Compartment block is a easy block, it's a superficial block, and it's important to understand that with this interfacial plane block, or plane block if you want, you can block more than one nerve. This talk is not about a discussion how many nerves you are going to block, if the obturator block obturator nerve is blocked or not. It's just to have an idea about what and Fasciliar block can deliver for hip surgery. And because it's already an old block, you will have a lot of conflicting results because the technique changed a lot over the years, of course. If we look at the history of the Fasciliar Compartment block, it was already discussed or already described in 1973. At that time, it was a blind block described by Winnie, and over the years, it's evolved to an ultrasound guided approach, which at that time by Dolan was more or less the same as you can still find the infrainguinal approach like it is today. In 2011, Peter Hebert did an anatomical study, and he looked at in cadavers at a new approach, the suprainguinal longitudinal approach, and this got really my idea of my intention to do some more research on that. If we want to talk about the Fasciliar Compartment, we have to know what the definition of this compartment is. And just to put it very clear or simple, the Fasciliar Compartment, you can see it as a kind of virtual tunnel. And the posterior side of this tunnel is formed by the iliac and the psoas muscle. Anteriorly, you have the Fascia itself, and the Fascia iliaca, it's not fixed to those muscles. In between, we have some nerves and we have some vessels as well. And the idea is to put a needle in this virtual tunnel, in this virtual compartment, to deposit a large amount of local anesthetic, and then the local anesthetic will find its way to the nerves you want to block. During my PhD, I did a lot of studies. One of these studies were anatomical studies. This was a study I did together with Gerben Troen, who is also a big anatomist. And this showed us that if we want to be able to block obturator nerve, or if we want to have a good spread to the nerves, we need to get the local anesthetic as proximal as possible. So I think it's important to have the local anesthetic much more to their origin of the nerves. And therefore, we designed, or we looked some more into this suprainguinal fascia iliaca approach. Now, Philippe already told that the separate nerves are important and anatomy is important, because without any anatomy, we can't develop a regional anesthesia technique. But we have to also think a little bit out of the box and ask ourselves, what is the value of all those separate nerves? And Philippe already showed this article from Short, which is a very nice article. It's an article from 2018. It shows us very well the femoral high branches, low branches, the obturator high and low, and also the accessory obturator nerve, which in this case, they had an incidence of 54%. So it's very important to know your anatomy, to know what you're doing. But it is still anatomical studies, And I think the clinical part is important too. Philippe already showed you this article as well. This is a very nice study. It has also, for me, it changed my idea how to look at blocks, how to look at the fact which receptors and fibers can be important in your postoperative management. But these things are all not that new. We started thinking of them because we have now better imaging techniques, and we are developing more regional anesthesia techniques. But in fact, already in 1979, all these nerves were already discussed. And if we go even further back, in 1948, all the higher and the lower branches of the femoral and obturator were also discussed. So this is not all that new. We just started to look at it a little bit in a different way. For me, I think that clinical importance is still something we have to look for more. And that's why I wanted to not just discuss the block itself or the fascial compartment approach itself, but also wanted to show you that sometimes you have to think a little bit out of the box. And it will get clearer further on in my talk. So what is the clinical importance? I think it's important to look more at the clinical part and not only look at the nerves themselves. Again, nerves are very important, but if you look, for instance, at this study for the accessory obturator nerve, you see that the average prevalence of this nerve is 13%, and this is the average in some studies. Philippe was lucky because he had much more percentage. Again, I don't think it's just about the nerve itself. And therefore, and I already said that, it's not the discussion if the nerve itself is part of a compartment or not. Philippe already showed you these articles, so I'm just going to go over this. So we need to focus more than the nerve itself. And now I want to show you a little bit about the technique, of course. Is the fascial compartment a good alternative for postoperative analgesia after hip surgery? To know the clinical benefit, we have to know how we have to perform the block, and therefore the approach and the volume is, of course, very important. In this topic, I did some research for my PhD, and in one of the research we did was we compared the infrainguinal and the suprainguinal approach. Remember that I told you that the proximal spread is probably much more important for the clinical manifestation or for the clinical use of this block than an infrainguinal approach. That's why we compare this, and in the study, and then you can, if you want to see it more practical, so if you put your probe on your ligamentum inguinale and perpendicularly, you should have this image, which is a bow tie or a bow tie sign. With the fascia iliaca, you have the ending of the sartorius muscle in the more distal, and more proximal, you have the oblique internal muscle. You're going to put your needle underneath this oblique internal muscle. A lot of times you see an artery, the circumflex artery here, pulsating, and the idea is to put the local anesthetic, as I already told, as proximal as possible. So by hydrodissecting the plane between the abdominal muscles and the iliac muscle, you can put your local anesthetic in the pelvic cavity. This is what also Hebert described in this article already in 2011. So your abdominal muscles, the iliac muscle, put your needle in between and put your local anesthetic. And this is the suprainguinal approach. And by doing so, we saw that the local anesthetic, in this case, it was an MRI study on volunteers. We saw that the local anesthetic and the dye got much more more proximal, but it was not only going more proximal, the amount of local anesthetic was also much bigger if you did the suprainguinal approach. So you could get a local anesthetic much more proximal in the fascial compartment, which probably has an effect on the clinical use. It's not, and of course that it's those things, you can't separate them. It's not only the approach, but also the volume, of course. And I did another study with Xavier Salablanche, and that's you know him from the Spanish. It's a Spanish anatomist, anesthesiologist, who is also very famous. And we saw that if you inject 40 mL, you will get a local anesthetic, and this time it was on the cadaver research. You will get a local anesthetic or the dye not only on the femoral nerve, the lateral femoral cutaneous, but also the inguinal nerve and the subcostal nerve. In our study, we even had some dye at the obturator nerve, and you see that the local anesthetic here got to the posterior side and the medial side of the psoas muscle. Again, I don't think it's about the obturator nerve itself. It's also about receptors we have on the psoas muscle. It's also about other smaller nerves we have in the same compartment. So for us, the suggested volume and approach was the suprainguinal approach and 40 mL to get the local anesthetic as proximal as possible. Afterwards, we did some clinical studies, of course, and as well for and as well as Philip showed for his Peng, we also had some very good results. We got a significant morphine reduction after 24 and 48 hours, and we also got an important decrease, or a significant decrease in VAS scores, which is of course an estimate for patient satisfaction. I know that one of the discussions is that we use a lot of volume, but in this study we used 40 mL of 0.5, which we normally not use anymore for just the total hip replacement. But in the highest concentration and the highest volume we used, we still didn't got any toxic thresholds in our plasma concentration study. So it is safe to use that amount, and I think that for other studies, for other approaches, people use a lot more than we use. So I think it's safe to use this volume, and it's also necessary to use this volume. And I had a nice talk with Serkan Trugan. For those who know, he's doing a lot of research in the ESP block, and he also said, and it was also in this article, that volume and the exact location of the needle is very important. That's also what Philip said, that you have to get your needle in the right spot, because if you don't have it in the right spot, even for the Peng block, you can have a motor block, or you can have some other complications. Efficiency of fascial compartment block. It's not only my study, of course, or our studies. A lot of studies already showed that if you do a fascial you can have a lot of clinical advantage of that. Another thing I want to focus on, and it's not only about the technique itself, is that there are a lot of biochemical properties of the fascia we don't know yet, or we didn't look for yet. For those who are interested in interfacial or facial plane blocks, this is a very nice article of Azalkawi, Amit Power, and Mariana, which are very good researchers as well. And this article handles about the basics of interfacial plane block. And one of the things they discuss as well is the biodynamics. And to fully understand the clinical effect of the role of an interfacial plane block, biodynamical behavior is very important. And I think there's a lot of research still we have to do, because there are a lot of unanswered questions. And I was also very interested in this research, and that's why, because we wanted to investigate if there was a possibility, or if there was even a thing about the effect of this. And on a Sunday morning, my colleague and I, this is David van Aken, who is also very active in the European society. We did some pilot studies, and there we try to mimic we asked the surgeon to mimic some perioperative movements. And you can imagine if you put a local anesthetic in a fascia plane, and you put in 40 mL, and then you start surgery, and you start moving the leg and moving it all directions, it can have an effect on the spread of the local anesthetic. And that's what we always also saw in our pilot study. So we injected at one point, we did bilateral fascial compartment block, and then at one side, we did a lot of passive movements mimicking the surgery, and we saw that at that side, the local anesthetic was much more proximal and in a bigger amount as well. So just to prove that passive mobilization of in the perioperative period can have a big effect on high volume blocks as well. This is the study we did, and we did some calculation on that, and also it proved that, or it showed that we have to take that into account. So what do we do now? Which technique should we choose? I don't think that the technique alone is important. I think you have to look at the different properties. And to show this, I don't know if people of you followed the RIUK meeting last, and they at that meeting they asked some very prominent people, and you all recognize them because they're very famous. Asking, what would you have, or what would you like to have when you have a total hip replacement? And I can already discuss you that all three wanted something else. So there is no fixed technique you have to choose or you have to take in order to get the best treatment. There's still a lot of discussion, obturator nerve, motor sparing, lateral femoral, but I think the discussion should not be to the nerve technique itself. I think we also look at the clinical scenario. And that's already something Philippe already showed as well. We have a lot of different scenarios, and the pain is not coming only from the bone itself, but it has also effects on the skin, the muscle, the fascia, and other parts. For instance, and this Philippe showed this as well, you can imagine if you're doing a hip arthroplasty, the incisions of the skins are only very small. So the importance of this cutaneous innervation is much more less than if you have big incisions. On the other hand, you put a lot of fluids in the hip joint in order to get a good image, and you can imagine that the distension of this capsule can cause a lot of pain, and you have to adapt for that. On the other hand, it's a half an hour or an hour after the surgery, this distension is gone, so this pain you will have from the arthroplasty can go away very quickly as well. Again, the fractures, some of the fractures are fixed with some osteosynthesis, with parallel implants. Other ones have a lot of skin infarction or a lot of skin intervention as well. So again, I think you have to adapt your local anesthetic technique you have to adapt your peripheral nerve block technique to the surgery which is performed. The same is true for hip replacement, but not only for hip replacement, but even the revision has, or post-structic fractures has other implications if you use traction or not, because you can imagine if you lose a lot of traction, the traction is not only on the bone, but it's only on the ligaments, on the muscles. So you have, it's important to take that in account as well. In our hospital, we do a lot of acetabular osteotomies. I don't know if you do that as well, but the idea behind it is that you break your hip region in 3 different places. So this is very proximal. So it's important to have a proximal block. It's not only about the capsule here, but also about the innervation of the underbones. So what is the importance of the clinical presentation? Where is the pain coming from and where is the pain situated? That should determine which block you do. And again, I want to just take you along on this little case report and something that made me think as well about what we are doing. I want to present you this male, the 85-year male who slipped on the ice in the winter, and of course he had a trauma, he had a fracture, and he came in the ER at our hospital. And we have the policy of when somebody comes in to give him a regional technique. In this case, I gave him a Peng block because, yes, I am also a fan of a Peng block, not only the Fascia iliaca. I did him a Peng block, and half an hour later, I went to him and said, how is the pain doing? I said, the pain is much better, but it seems to have moved. I had a lot of pain in the front, but now I have still a lot of pain, which is much better, but I have still pain in my buttocks. That made me think about patient satisfaction. We can give something, but it doesn't resolve anything. So we know, of course, that knowledge of the nerve corresponding to the surgical guide is crucial, but I think also pain location site is very important. Then, of course, we have to go back to the anatomy because we know that the anterior part is very important. But in this particular case, this person was, after an anterior block, he was complaining a lot about a posterior pain, of a residual posterior pain. He was only going to be operated on the day afterwards. He was an old man, so we are very reluctant in using a lot of morphine in these guys, even if we, especially when we try to give him already a regional technique. If we have to go back to morphine, then it's a little bit pity. For the posterior part, and Philippe already told you that posterior innervation is something maybe less important, but can be very important as well. But for the posterior part, we need a posterior technique or something. That's why I like to think not only in cases of the difference between the Peng and the Fascia, but I think it's much more important to look for difference between the anterior and the posterior segmental anatomy, actually. And indeed, if the pain is anteriorly, or if we have I think it's important to have an anterior approach for most of the things, like, and you can use an Fascia or the Peng block, but you also have you need something for the posterior part as well. If we think about the posterior part, then of course, then you have to think about the posterior approaches again. I already told you that I'm not very trained in that because of the major adverse effects, and especially at that time. So together with David, my partner in crime, we started to think about some posterior things, and we went back to the drawing board. And we looked into a new posterior intergluteal approach. And I know that is not really in the face of this talk, because I only wanted to, or I needed to talk to Fascia, but still I want to tease you a little bit and just start thinking about some other stuff as well. We looked at a possible new posterior approach, and in fact, and I'm gonna just give you a little preview about preliminary results. We took a few of these in this pilot study. We took a few patients, and actually this number 2 patient here is the one 85 years old. So he came into the ER. So this is the fractured patient. It's not the hip replacement patient. The patient came into the ER, and he had an NRS score of 10. We did a Peng block, as I already told you, and the pain dropped to 6, so the Peng block really works. But that was the case. He still had a lot of posterior pain, so I did this posterior intergluteal approach, and then the pain even dropped more. He went to the ward. He was operated on the next day. We performed a Fascia the next day. He received a new hip, total hip replacement, and the patient was doing very fine. Just to say that we have to think about posterior approaches as well. The posterior innervation can be important. We're still in the process of developing this technique, but we did some cadaver research. We did already some MRI, and I think in the near future, and I hope I can discuss this some more in later events with Philippe as well, but I think this is something we have to look for. We don't have a name yet, but because of it's more like a posterior capsular nerve group approach, I like to think as that you have the Peng block as the anterior, and this could be some kind of posterior pericapsular. Some recommendations and proposals for those who were able to see the ESRA webinars. Of course, the time difference is not always that simple. You know the concept, or you don't know the concept, but the prospect guidelines is like the procedure-specific postoperative pain management. It's not only ESRA has these, I think, but it's some kind of guideline of some kind of pain management suggested by the European Society. And the first time they published this was in 2004. At that time, there was still a lot of thinking about epidurals. They were still thinking about intrathecal morphines, and not so much about peripheral nerve blocks. But you can imagine in 2004, not a lot of people used ultrasound. So, and it changed. The new guidelines of 2010, there was much more interest in peripheral nerve blocks, and intrathecal and epidurals were not the first choice anymore. Now, this year, 2021, new guidelines were published, and I'm happy to say that the Fasciliar Compartment block was introduced in these guidelines as well. And I'm sad that the Peng block was still too young to have a lot of studies, because I'm sure that otherwise it will be in these guidelines as well. So that will be probably for the next guidelines. To conclude, I started by saying that the block we perform, either is it a fascia iliaca or a Peng block, is only one part of the bigger aspect of hip surgery. We have to think about much more. We have to think about volume. We have to think about biodynamics, block testing, clinical relevance. We should not focus on the technique alone. Both techniques have shown to have some very good clinical results. So this is not a competition between the two, but we have to look at clinical manifestation as well. So we have to focus on the type of anesthesia and analgesia needed. We have to focus on clinical manifestation, type of the patient, comorbidities, and therefore, I'm still busy making a little flow chart on this, and this is how I would do it today in clinical practice. So if a patient comes in for a fracture, so this is only for the fracture patient, I ask him where the pain is mainly going. If the pain is operating the same day, I will do an anterior technique. I will wait half an hour, an hour. I ask if he still has some posterior pain as well. If that is the case, I give him a posterior block. If the patient is not operated on the same day, I will ask where his main pain is. If it's anterior, I do an anterior block. And for us in our hospital, we do on ER, we do a Peng block for anterior pain. If the pain is posterior, I start with the posterior block, and that's then the new block we are trying to introduce. And then we just ask whether. So I think block testing is important. It's not just about it's a fracture, we have to do this. No, I think you have to look for the result of your technique as well. I like to think there is more than just a technique. I like to think there are anterior and posterior regional techniques according to the clinical manifestations. Anterior techniques, you can have the fascia iliaca, you can have even the femoral nerve block if you're not that trained, or you can have and then I like to call it an anterior pericapsular nerve block. And for the posterior, you still have the lumbar plexus block, because in discussions we had on the Ezra forum as well, I heard that a lot of people are still using the lumbar plexus blocks, and maybe in future we can also talk about the posterior Peng block. I don't think it's a problem to combine them, even because we are not using that much volume. I think Philip told that he used 20 mL. For the posterior approach, I also use 20 mL, so that's 40 mL. And as I already told you, 40 mL using for a block is not that dangerous for the toxicity. So I think tailored anesthesia is very important, and therefore, and these are really the light slides, I promise you, the optimal anesthetic approach is still a debate. Adequate anesthesia is important, and we have a variety which have been all proven very useful. And I think the most important is still that the quality of the performed block is probably more important than the importance of the block itself. I, of course, am still a big fan of the Fasciliar Compartment block, and I think that this says it all, of course. I thank you for your attention.
Thank you very much, Kris, for that very nice presentation. I myself am a believer of fascia iliaca block, suprainguinal. We do it a lot in my hospital, and it has a very nice analgesia postoperatively for our patients. We actually use a lot of volume, but not as great as what you mentioned. Anyway, we'll talk about that later in the Q&A. But before we proceed to the Q&A, let me first call on Joseph Kujamat as I try to organize the questions. So, Joseph, let me first call on Joseph the CEO of Visonic, as he will speak for a few minutes while I try to organize the questions. Okay, Joseph.
Thank you, Doctora. Okay, I will just share my screen. Can you see the screen right now? Okay, thank you to our distinguished speaker, Dr. Philip and Dr. Kris, and also with our moderator, Dr. Peng, and our sponsor, Visonic, and our local partner, Duran-Bitter. So what is point of care ultrasound? It is the revolutionary in the practice of medicine, influencing how care is provided in nearly every medical and surgical specialty. With point of care ultrasound exam, it is aimed in answering a specific question with a more focused, goal-directed examination that is to be used to assess most body systems. Like the piloter, it is for pain management, Navi for anesthesia, and Carnation for ICU. With every model, we can fit a specific clinical application in any field of medicine. With point of care ultrasound in anesthesia, it benefits anesthesiology. That is, you compare it with blind injection and simulator. It reduces the risk and nerve injury, and it makes puncture completely visible and safe. It has a dedicated design, large touchscreen, enough for anesthesiology to see the images across the room. Seamless touchscreen supports liquid infection prevention, even with alcohol. And with its electric height adjustment, anesthesiologists can use the cotton swab to adjust the height of machine so that it can keep their hands clean. And with its long battery power, it supports up to whole day scan time, and anesthesiologist doesn't need to consider the power supply when it moves the machine to a different operating room. And with our needle visualization, it's very hard to recognize needle in clinical application, but with anesthesiology ultrasound, it can sort it out. The left video is intelligent needle recognition. It can recognize the direction of the needle and steer the sound beam intelligently so that the sound beam is perpendicular to the needle. This will acquire better image of the needle. The right video is WeGuide. They can use the magnetic technology to track the needle accurately. With our WeNerve AI recognition, artificial intelligence is also changing the way we do recognition. We can use a different color to label different tissues. As we see in the video, the red is the muscle, the yellow is the nerve, and the blue is the bone. And this is one of the best features of our ultrasound, vCloud Share. vCloud is real-time data transfer, remote diagnosis, and remote service platform. As the video shows, it can transfer the data so fast from ultrasound machine to mobile phone. But then, of course, we have to consider our internet capabilities in every part of the world. And with our ultrasound, we have a vast selection of probes, and with anesthesiology, we have special probes designed for Navi. We have the single crystal convex, the ultra high frequency, the small footprint, and we have a very high frequency linear probe. And what are the benefits of ultrasound guided anesthesia? It helps a doctor observe tissue images in real time, reduce the risk of puncture in operating, and relieve the patient's pain after the operation. That's it. Thank you for your time. I'm Joseph, the General Manager for the Ranbiter here in the Philippines, representing Visonic. And I would like also to thank, in cooperation with PSA, Dr. Pence Mara. Thank you.
Okay, thank you, Joseph, for that. Now we go to the Q&A. The first question goes to Philip. Philip, they are asking again, can you explain how to prevent intramuscular injection during Peng block?
So just walk through is most of the time when you touch the bone, when the needle touch your bone, doesn't mean you're on the bone, you indent the tissue. So then you don't keep pushing like orthopedic surgeon. You just find rotating skill, just pierce through. The first thing you do is you puncture, when you're on the bone, if you're actually using piercing function, you'll be inside the, we call iliofemoral ligament. It's very thick. Believe me, if you actually scan the Peng area and scan down and see the femoral head, and you suddenly see there's a thick ligament that you didn't notice. So that's the reason why if you do this, the first thing you do, you inject, you cannot inject. So it's most of people will experience. Fine, I don't care. So you just go through, touch your bone and pierce through, you dip into the ligament, but then, and you ask the assistant to put the pressure there. And while you're putting a pressure, the assistant put the pressure, you pull back slowly, then you can see the fascial lift. So usually it's not a problem when you actually just keep rolling the needle. If you cannot see it, just go back again and keep rolling the needle, pierce. I find that the most difficult one, so I have done the whole spectrum. If it's a hip fracture patient, is usually is not a problem because there's some capsular hematoma and sometimes an extra capsular tract of the blood. So it's not that difficult. The most difficult is my spectrum is a young patient. When they're 16 years old, they have some avascular necrosis. When I have to do that, it takes forever for me to keep piercing through. I would say I always see the fascial lift. If you don't, that means actually you are not piercing through enough. You just take a little bit patience. By doing this, you avoid this, number one. Number two is, I find that if your needle are much closer to the AIIS, there's possibility that you spill out. So I usually just go between the AIIS and the iliopiped eminence, just a touch close to the iliopiped eminence. So remember, when you go there, you worry about hitting the femoral nerve. So I toggle the probe so I can go a little bit closer. Number one is easy to pierce through, and number two is difficult to track back to the AIIS or even ASIS area. So these are two things that I usually do. Just for information, I do alcohol as well. So for me, it's a big no for me to inject anything in the muscle. So far I haven't had touch wood. So because of patience, I just were patient and pierce through. Yeah.
Okay, thank you for that, Philip. Now let's go to Kris. Kris, you mentioned that there should be a great amount of volume, at least 40 cc. Now, for you to block the obturator nerve, if you would use a lesser volume, would that mean that you will not be able to block the obturator nerve?
This is the discussion we have been talking about a lot. And that's the discussion I wanted to go away, actually, because I think it's still very difficult to determine if the obturator itself is blocked or not. And I think the literature already showed both ways. Recently, and Philip showed that article as well, there was a new publication that the obturator nerve was probably very difficult to get. On the other hand, in the same journal, there was another article determining the minimum volume used to block the obturator nerve. So there's a very vivid and very nice discussion. But my message of today should be that the nerve itself is not that important, I think. And the proof is that another article published by Philip and his colleagues was that the obturator nerve was even not important if for a total hip arthroplasty. So we're focusing in literature a lot about nerves, but then you see that the clinical implication is maybe not that important. I think for sure, and we don't know all the answers yet, that getting the local anesthetic, for instance, around the psoas muscle is very important as well, because we use a traction table for total hip arthroplasties, and if you get elongation of muscles, elongation of fascia layers, elongation of whatever, also can give a lot of pain, and is also very important in the pain management. And that's also where Philip started with, that fascia layers, that muscles, that skin is very important in your pain management as well. So I think the direct effect of the local anesthetic, and we use 40 ml because the psoas muscle is a very long muscle. It's the longest muscle in the body. I think the local anesthetic itself has effect on much more than only the nerves. And therefore, I think if you have a local anesthetic in this big compartment, you can catch much more than just a femoral nerve or lateral femoral cutaneous nerve, or maybe even an obturator nerve. And I like to think that you can reach the obturator nerve and that you need volume more than 40 mLs, because you have to reach above the level of L5S1. But I don't think the discussion or the clinical effect is only depending on that little part of the block itself.
Okay, so
Peng, can I just make just a quick comment? Is it possible? Yes. Or so Kris, actually is I agree with Kris. Actually, we just put the obturator nerve aside. Oh, by the way, Kris, whoever have been with me is my friend, so you are my friend. Don't worry about that. So just put it aside, the obturator nerve, especially the article that the obturator are not important. In the presence is important. In the presence of other nerve block, the additional obturator are not that important. With the presence of other block for hip surgery, that's important. And I'm also a fan of a super Erector, the fascia block, not infra, but super, because think about this. It really target the articular branches because it's high enough. It target the femoral nerve, which we don't intentionally. We target the larger femoral cutaneous. You basically cover more, and so you have more intense. But if the superior Erector fascia block are not giving high enough volume, you are just femoral nerve without articular branches. You need to spread high. So that's why super Erector with a high volume basically is cover more with a Peng block. Yeah.
Yeah. And that's what I say as well, because some people might think that we're some kind of concurrence or some kind of against each other. But I do use I already performed Peng blocks for fractures, because I think for a fracture, Peng block is a very good alternative, especially if you put in parallel screws or I think it can be a very good alternative. And the only thing is that it's a quite new block, so the big studies still have to come. The experience of a lot of people still have to come, even if I'm a very big fan of the Fasciliar Compartment.
yes, I also believe that way, Kris, that Peng block is very effective for hip fracture. You deliver Peng block at the emergency room and it's very effective. Now, my question to both of you is, you mentioned, I saw this paper of Philip wherein they said that the obturator nerve is really not very important when it comes to hip surgery. But we know that there is an articular branch of the obturator nerve to the hip. So what do you mean exactly by that? That when you said, both of you, that it is not very important for hip surgery when it comes to analgesia. Can you expound further on that?
Okay, so this is a very good question, by the way. So if you think about this, if you think about the hip capsule as a 4-quadrant, the obturator nerve is a bottom feeder. It's a bottom feeder. So basically, in a way, only the bottom. All right. So if you think about hip fracture or total hip, so let's divide into two. Hip fracture, if you have a fractured neck, and you don't really need the obturator at all. Period. Zero. If you actually have the fracture in the trochanteric area, you still actually get most of them. So if the contribution for the bottom is not that important. Now, if you have total hip replacement, most of the cut in the capsule is in the anterior and lateral, if the anterior approach, or posterior. Basically, there's nothing to do with the capsule, whether it's obturator or not. So think about this: the obturator is not really contributing a lot, but it contributes something. So, but that's why it's important in the presence of other nerve being covered. It covers maybe 20% or 30%, or sometimes even less, depends on the type of injury or the insult. So that's the reason why when you do a massive RCT with a multimodal analgesia, with also the drug as well, the presence of obturator are not that, the noise are not that big. And that's the reason why you don't see a positive impact. So that is the reason why you don't see obturator in clinical study.
Okay, thank you for that explanation, Philip. Now we go to Kris again. So you said that you need a very large volume for a single shot fascia iliaca block. So if you would place a catheter, how would you now go with the volume hourly? We usually do it 5 to 10 cc mils per hour, right? For a continuous catheter. But what about for fascia iliaca? You said that you have to be able to block that area of the psoas muscle, which is a very large muscle. So how will the volume go on an hourly basis?
Okay, first of all, the use of catheters. I don't use a lot of catheters in my practice. For the fascia iliaca, I don't use them for elective surgery because of your working, the surgeon is working on the hip joint, is working in the same area, and they don't like it if you put in catheters. And also, I don't think you need it for hip surgery because it's not that painful that you will have its continuation for different days. So I think you can do it once or you can repeat it. What did I use it for? I did use it for people, elderly people who had fractures. They chose not to be operated on anymore. Oncological patients with fractures, then you can put in a catheter. I did it more on case report basis and not on routine basis, but it was more for giving people comfort in their last days of their life, actually. And then you can put in, like you said, 5 or 10 mLs an hour, but toxicity in this case is not that important anymore. So I think it's two different things. I think you probably don't need to get a catheter in because, face it, the hip surgery is not that painful in comparison with, for instance, knee surgery. And second, it gives some practical issues. And beside that, I'm not a big fan of catheters anywhere. So for shoulders as well, we still do some for total shoulder replacement. But I think, and I already talked about that with some colleagues, maybe it's better to do a block the day of the surgery and repeat the block the day afterwards. But yeah, that's an all other discussion, I think.
Okay, so Kris, you performed the block before the surgery or after the surgery?
I performed the block before the surgery, and a good indication for that is, some people might have read the study from Shariat, which is already an older study from, I think, 2013 or something, in which the fascia iliaca block was first introduced on a big scale by famous people then, I would say. And what they did is they performed the block after surgery, people already having pain, and then it's very difficult to be patient to let the block work, because for every local regional technique you have to put in a block, but we all know that it takes 20 minutes before it really works. And if somebody is in agony of pain or has pain postoperatively, then 20 minutes is very long, and you will probably have to give a lot of morphine to cover those 20 minutes. You have to already have a lot of opioids during the operations. So I think, and I think that's for every technique, you should give the regional technique before surgery to benefit for it for the most.
Okay, thank you for that, Kris. Now, Philip, 2 questions. The first question is just like with Kris, do you perform the block before or after the surgery? And the second question is, what is the ideal volume and concentration when you do the Peng block?
At the present moment, we use Peng block mainly for the hip fracture, and yes, we are doing this for the anterior approach. So that means actually we always do it before the surgery. The volume it is a kind of interesting. So we use 20 cc in every single one, but I understand actually we overdose the patient. So 10, 15 cc is good enough. So, but then you have to think. So when we have a deal with a team with a lot of people, so I would say if you have a fractured neck, 10, 15 cc is good enough. When you have a trochanteric fracture, 20 cc is recommended. But no one will go to look at the hip fracture, what type of fracture. So everyone just put 20 cc. So I think 20 cc is good enough. 0.5 or 0.75 of ropivacaine or 0.25 of bupivacaine is the volume we use.
Okay, thank you for that. Now, another question for you, Kris. Lumbar ESP has been used for hip surgery. How would you comment on that? Lumbar erector spiny block?
Yeah, it's not really my topic, and I think there's a lot of discussion on that as well. I think I just mentioned it because I wanted to show that volume and the exact location of the needle is important. That's also important for the Peng block. But I'm not a specialist in ESP. I asked the question on the ESRA forum once, and just like every other technique, you have a lot of people against it, a lot of people loving it or want to introduce it. I think it's just too early to really understand if it can have an effect or not. As for today, I don't have experience with that. And if I look at the anatomy, but there are a lot of other people, and I think that Philip even can answer that much better. I think it's anatomical challenging to use the ESP for hip surgery.
Okay, now for Philip. So many questions actually. So, what about continuous catheter for Peng block?
Yeah, so I don't do continuous. I rarely do continuous. So, and also I know my colleague have tried to do it. One of the thing about this, to enter the fascial plane, you need a sharp needle, and when you do continuous, you use a blunt needle. So that is a problem. So to get into that fascial plane. Then we tried the benzoids that pajang the needle, the catheter over the needle, and that actually is probably the best because it's a little bit easy to get into the plane, but it won't last long. So we probably use it for the next dose because actually it lasts for 18 to 24 hours. There is an article published, and I reviewed the article as well, that they do continuous. This from Italian group. They find that the 3 out of 20 they have some frank blood, and they just scare. Okay, so and they didn't know. First of all, when you put the needle on the bone, you are actually puncturing. You are puncturing the iliofemoral ligament. All right, so you are puncturing this. Usually, it's just on the bone, but when you have a fractured hip, you have a hemoarthrosis by nature, bound to be. I mean, you have a fracture, your blood there. So I believe that actually you puncture that, you are actually aspirating some of the blood from the joint. Because actually it's that continuous block, they say that they have done, they see the blood. The plane is fairly avascular. If you have a dissect, they're fairly avascular. There's no big vessel. You put a big needle and still can aspirate nonstop. I'm pretty sure they are actually doing the intra-articular hematoma aspiration. So I don't do much continuous, and I think it's a very difficult one. If you do it, I suggest you have that Pajang technique, because actually it's a catheter on needle. The needle is sharper, much easier that way.
Yeah, I also came across an article, Philip, about incidents wherein they kind of, when they place a catheter, it becomes bloody. There's that was to an article that I've read wherein when they were placing a catheter, there was blood on the catheter, so they did not pursue with the continuous catheter and they only did a single shot. Now there is one last question. We had too many questions, and this is the last that we are going to entertain. Philip, the question is for you. For surgery for involving the posterior capsule of the hip, aside from the Peng block, what would be the other block that you would do?
So interesting, Kris. We need to have a talk. So just to give you some perspective, you have a snapshot, but we have a big volume. So among all the hip fracture, I would say the anterior capsule contribute most of pain. So we have a big cohort of 180 patients we look at, and around for those who have the Peng block, around only 20 to 25%, they have residual posterior pain that needs supplement. So overall, this is a denominator. Now we have a denominator. So what are we doing? So we look at the posterior capsule. So things to stand out is number one is the nerve to cortices femoris, which is very hard to find. The superior gluteal is easy to find. Easy. It's actually between the gluteus maximus and medius. I can find with 1 second, but it's only there on 20%. And then the branch for a single praxis is difficult to find, is inconsistent. Now, with that knowledge in mind, the best way to do it is to find a posterior capsule. When I look at your ultrasound picture, it's the first time I look at this. Basically, you are doing a true Peng, you are doing pericapsular. But where is the best capsular area? So we find out basically, again, don't want to give you too much all this, it's a posterolateral superior capsule. That is a safety zone because it's further away in case of any problem, further away from sciatic nerve. And actually, that's a plane, if you go back to your drawing board and the anatomy dissection between piriformis and the superior jamenis. And you can see the capsule, you can put a needle there and you can dissect, and it will actually have a pericapsular. So I think posterior is very similar to anterior. You don't want to aim at the nerve, you aim at the capsular infiltration, and is how to find that spot. So to answer this, I won't do it as a routine if they have this. So we especially say for the group in Hong Kong, we are actually doing this only when they complain after the anterior. I think the key is posterior capsular, but again, I don't want to give out too much because we haven't published it yet. So we are writing this up, and we'd like to talk to Kris a little bit more about this. We have looked at this work in depth as well. So that's why I say posterior capsule, don't minimize this. There's something there, but not a lot.
Okay, so can we also apply, actually this is done by surgeons for posterior capsule surgery of the hip, local infiltration anesthesia? Would it
Only
also,
when they do posterior approach.
Yeah, okay. So one very last question, Philip. They are asking if you use adjuvants for Peng block.
I don't. So the only adjuvant that we think that most effective is dexamethasone, but then we can give it IV. So we don't add any adjuvant. Yeah.
Okay. What about you, Kris, for suprainguinal fascial yaka?
Same. I agree with Philip, and I think a lot of people agree with that. If dexamethasone is the best one, but you have to give it intravenously.
Okay, so both of you don't use adjuvants?
No.
No. Okay. So before we wrap up, I just have some few reminders. Okay, so for the Philippine anesthesiologists, we have the forthcoming mid-year convention. Now the last day for the reduced rate will be on May 31. So kindly register now before that reduced rate becomes a higher registration fee. Next slide, please. Now, this is an International Symposium of Ultrasound, ISURA 2021, with Philip as one of the faculty. This will be on June 4 to 7, 2021. It's barely only around 2 weeks to go. So kindly please register, and Philip will be there. Third slide, please. Now we have Meet the Experts in Regional Anesthesia. This is by Wisonic. We are already running on the 4th webinar. This is with Dr. Toglu. This is going to happen next week. And these are the dates. You can just log on, or the Wisonic people will be there to try to remind you of the dates that are forthcoming for the lectures. Next slide. Now, when it comes to the webinar of the Manila Academy of Regional Anesthesia, please go to the website, manilaacademyra.com. And then a lot of you have been asking questions about the proceedings of the lecture of Philip and Kris. Then you can go to the website, manilaacademyra.com. We'll be posting it in that website a few days from now. So you don't have to worry. If you want to go over the lecture of Philip again and Kris, just go to the website, and Wisonic will also post it on their YouTube channel. Okay, so now to wrap up, we have actually learned a lot from Philip and Kris about the effect of Peng and Fascia iliaca block. They are very two different techniques, but based from experience, we know that they really work. We have seen it in a lot of our patients. We have seen that after the surgery, the VAS score of our patients are only 1 to 2. Now we just have to perform it in the right manner that Philip and Kris has taught us. So without further ado, I want to thank Philip and Kris, are very illustrious speakers for tonight. We want to thank you from the bottom of our heart. We have so many attendees, not only from the Philippines, but around Asia and actually around the world. So for us in the Philippines, we bid you all good night. From Philip's end, it is good morning. And from Kris' end, it is good afternoon. Philip, my heartfelt thanks. And also Kris. Kris, where are you?
Here, I'm still here.
Yes, we hope we could invite you again one day.
Yeah, thank you for the invitation, and thank you for the nice talk.
Yeah, I hope that day will be face to face, not anymore just through online, just like this one. So I hope that one day it will be face to face. Okay.
Looking forward.
Yeah,
Thank
me
you.
too.
Thank you
Me
very much.
too. The sooner the better.
Yeah, thank you. So now, Jensen, you can come in for your reminders for the evaluation for the attendees from the Philippines to get a CPD certificate. Okay.
Okay. Thank you for the presentation from Dr. Philip, Dr. Kris. Before wrap up this meeting, please remember to fill out the survey of this webinar. Then you will receive the certificate. The survey will be shared in the browser when the webinar ends. And finally, I'd like to thank you everyone who made this meeting possible, and we hope to meet you again. Thank you, Dr. Philip and Dr. Kris and Dr. Peng, Mr. Josh. Okay.
Okay. So that's it.
Yes.
That's it for tonight. Dr. Angel Gomez, I'll send to you the contact number. Thanks for attending, everyone. Good night.
Thank you.
Good night. Thank you, Doctora. Thank you,
Have a
Jensen.
nice- Thank
Thanks,
you.
Jensen.
Thank
Thanks to
you.
all the participants. Take care and good night.
Okay.
Bye.
I'm going to wrap up this meeting.